me in. Hopefully this lecture won't be more than 1 hour, and then we can go through questions and answers. It's mainly dedicated to the R1 residents or senior medical students, focusing on the neurological emergencies that we see in the emergency department and how to manage them during the first hours of presentations. And probably there will be like a few diagnoses that we see as an emergency, mainly time-sensitive diagnoses or diseases that we address. And the main presentation that we always be concerned about is an acute stroke in the emergency department, either ischemic acute stroke or hemorrhagic acute stroke. We're going to talk through the approach in the management and differential diagnosis of such neurological emergency. I'm going to ask some questions. If possible, please answer through the chat, enter your answer. I think you can write your thoughts, your possible answers. Sometimes there is no wrong or right answer, but at least the interaction and when you get involved in thinking about the process and the management will help us all understand the approach to such patients. Okay, so the main objective of the first part is the definition. So we'll have to go through the definitions of acute stroke, the classification, and the classification, obviously, we have ischemic and hemorrhagic stroke. And under the ischemic, we have transient ischemic attacks, which is basically temporary ischemic attack, and the hemorrhagic stroke with all the subcategories under it. Mainly is subarachnoid hemorrhage and intracerebral hemorrhage as the possible common diagnosis that we see in hemorrhagic stroke. So when it comes to the definition, ischemic stroke is basically a blood clot that stops the flow of blood to an area of the brain, as simple as it depicted here in the picture or the diagram. Hemorrhagic stroke, it's a weakened and diseased blood vessel that ruptures and then bleeding occurs and the blood leaks into the brain tissue, either it's subarachnoid hemorrhage or intracerebral hemorrhage. So what is the definition of transient ischemic attack? So if someone asks you, what is a transient ischemic attack definition? You can write it down in this chat box. Please try not to use ChatGPT or Google. You can try it at least to have an idea about what is the common definition or the definition that you think. Okay, so some people, they say mini stroke, okay. Ischemia that got better, okay. Last a minute, so Khalid, he thinks it's time related. Recovery within 24 hours. Okay, you're close to that definition, but can you elaborate more in terms of definition? Temporary ischemia, transient neurological deficits, clot that moved, okay. Transient episode of neurological disease, I guess, without acute infarction, okay. Stroke with full resolution of symptoms before 24 hours. Symptoms that gets relieved within 24 hours. Okay. Okay, so some of them actually, as part of the old definition when it comes to time, in terms of resolving symptoms, but recently there is a new definition for for transient ischemic attack. It is called the tissue definition. So it is transient. Transient means temporary episode of neurological dysfunction. So there is the neurological dysfunction, and it is caused by a focal brain ischemia or spinal cord or retinal ischemia without acute infarction. So the trick here is that there is no acute infarction. It's just an ischemia that improves. There is no specific time for it. It might last a few minutes, 1 hour, 24 hours. The definition doesn't address the time here. It is reversible and transient or temporary, and it can happen in the brain, it can happen in the spinal cord, and it can happen in the retinal organ. So this is something to keep in mind when you're dealing with a patient with transient ischemic attack. Okay, ischemic stroke, there is a thrombotic and embolic stroke. So what's the difference between a thrombotic and embolic stroke? Okay, so you can see here, thrombotic stroke is basically a blood clot that blocks the flow of blood in the brain. And an embolic stroke is a fatty plaque or blood clot that embolizes, breaks away, and flows to the brain where it blocks an artery. So it's coming from a different venous site that suddenly embolize and it goes and block an artery in the brain. So that's the difference between thrombotic and embolic. The difference is when it comes to the management, because if it's an embolic, do you know what's the common cause of embolic stroke as a disease? What's the disease? Excellent. طيب, it's atrial fibrillation. So you have to think about atrial fibrillation when it comes to acute stroke. Does the patient have atrial fibrillation or not? You have to get an ECG. You have to check that. A DVT also might cause that, but most commonly it's an atrial fibrillation that causes embolic strokes. Okay, so time is brain. You need to make sure that the management and the treatments or the revascularization of the brain is done as soon as possible. Early notification, pre-hospital system. So you have to pick up those patients or recognize them from the field. And this is very important because some people or some patients, they come in late to the emergency department. And if it's a late presentation, it's going to be very difficult to manage those patients. So this is something that you have to keep in mind when recognizing this, especially in the pre-hospital or ambulance system. The common thing that we use, even here in Saudi, is the fast mnemonic. So the fast basically includes the face, look for an uneven smile, an arm drop, check if there was any arm weakness, speech, listen for slurred speech, T for time, call 911 or 997 at the first sign to call for an ambulance to come as soon as possible. This is also has been extended to be fast. So now we also check for balance and eyes. So in the balance, we check for sudden loss of balance or vertigo. Eyes, we ask the patient if he has change in vision or trouble seeing. And then you go through the fast. The face, if the face or the smile looks uneven, arm weakness, speech, trouble speaking or aphasia, and T, when you call the ambulance service or 911 or 997. Okay. In the emergency department, if you're working there on a shift as a student or an intern or a resident, early CT scan and CTA, which is a CT with an angio contrast, you have to do it as soon as possible. And that's why we have, what do we do usually in the hospital to make sure that this gets done as soon as possible? If anyone works in emergency in a hospital and have seen acute stroke patients coming to the emergency, okay, yes, it's an acute code stroke. So some hospitals, or most hospitals actually now, they have a code for such presentation because you need to mobilize all the staff or the manpower, all the resources to address this patient to make sure that he gets everything done within a frame time that is very tight. Get the CT scan done, get the CTA, make sure neurology come and see the patients. He might need further investigation or further interventions, and everything gets done within a limited time. Okay. What do you see here on the CT scan? This is a CT scan of a patient with an acute stroke. He came in with right-sided weakness. You can write in the chat box. MCA sign. Okay, left MCA. Okay, excellent. Dense structure. Okay, excellent. So this is basically an early sign of acute stroke that we will see in a patient presenting early with an acute stroke, ischemic stroke, obviously, not an hemorrhagic stroke. So this is the hyperdense MCA sign or the MCA sign. Here it's in the left MCA because it shows you the left side here. So very important question. In the emergency department, you need to rule out stroke or acute stroke mimickers. So what are the possible mimics of stroke that you have to think about? You have to rule them out because you don't want to give TPA or an aggressive intervention to a patient who doesn't have stroke. Okay, so hypoglycemia is number one. You have to get the glucose checked, finger stick. What else that might mimic acute stroke? Tumors. Tumors rarely mimics acute stroke. Rarely, yes, because it takes time. Acute stroke usually happens quickly. Todd's paralysis. So Todd's paralysis can present with symptoms of an acute stroke. Post-ictal, excellent. Seizures, excellent. Migraine, excellent. Migraine with aura, excellent. Sepsis, yeah, sometimes if there is confusion. Electrolyte imbalance with some electrolytes like hypocalcemia, they might present, or hypokalemia, they might present with neurological weakness. Drug overdose like opioids doesn't give you unilateral deficits, but yeah, it might present like an acute stroke. Bill's palsy, yes, excellent. Okay, so all of these mimickers, you have to know them because when you're seeing the patients, you have to go through them, make sure that there is no mimics of stroke. Rabies is rare, but yes, it can present with neurological deficit that can mimic stroke. So you have to go through your differential diagnosis when it comes to acute stroke management and assessment in the emergency department. So you can see here, this is from one of the papers that addressed the misdiagnosis as stroke. So it could happen. So seizures can present as an acute stroke or mimics acute stroke in a significant percentage of patients, up to 40%. Migraine with aura, up to 50% that can present as an acute stroke mimickers. Also, there is psychiatric disorders, although it's rare, but I mean, rare when it comes to the differential, you want to keep it the last diagnosis after you rule out all the medical causes. It can present as an acute stroke, sepsis, syncope, transient global amnesia, brain tumors, labyrinthitis. Anybody knows what's transient global amnesia is? It's not a common presentation, but you would see it in the emergency department or if you're working in neurology. Do you know what's transient global amnesia? No, it's not dementia because dementia, it's permanent, it's progressive. Yes, so it's a temporary episode of memory loss. So it's transient, so it's temporary, so it's not permanent or progressive, and it's a global amnesia. A person would wake up in the morning and he doesn't have the memory of the past week. He doesn't know what's happening for the past week. He's like lost his memory for the whole week or the whole month. He remembers maybe the people by the name, but if he have seen someone yesterday or the day before, he won't be able to remember the events. So that's transient global amnesia. Okay, so always think about migraine seizure as the thing that might mimic a stroke. In addition to hypoglycemia, hypoglycemia is very important too. Okay, so most pre-hospital systems now, they're trying to get a mobile stroke unit. So this is in King Faisal Specialist Hospital. They have a mobile stroke unit because of the time you need to get things done as early as possible before the patient reaches the hospital. So it is starting to be available in some of the countries. It is money consuming and it's like a lot of cost, but if it's available, it will help a lot in getting the assessment done. So these mobile stroke units, they have a neurologist, they have a CT scan, with contrast so they can diagnose the stroke and immediately transfer the patient to the appropriate facility. So when it comes to an acute ischemic stroke in the emergency department, should you tube a patient with an acute stroke or not? So what do you guys think? A patient with right-sided weakness, he has difficulty speaking, he has dysarthria and aphasia. Okay. So why would you tube, if you say yes, why would you tube to tube the patients or intubate and manage the airway for a stroke patient? And if you say no, also why now? Why not? Okay. So oxygenation is very important, but we don't want to injure the airway. Depending on the GCS, okay. JCS first, and if he's stable, then no. Diaphragmatic paralysis, bilateral innervation, no need as long as the patient protects his airway. If the GCS is less than 8, according to his GCS less than 8, would have difficulty breathing. Okay, so just to give you an idea, so the Glasgow Coma Scale or the GCS is mainly developed for trauma patients with head injury. It wasn't developed for acute stroke. We still use it in acute stroke, but it doesn't help us in making decision to intubate or not. Even the trauma patients, now there's a debate about using the GCS to intubate patient just based on the GCS. The main thing that you have to know is that try to avoid intubation in acute stroke patients as much as possible, and I will explain why you should not intubate. As much as possible means as long as it's safe for the patient. If he's awake and his oxygenation is okay, his ventilation is okay, his breathing is fine, his vital signs are okay, then do not intubate him. And also the airway is protected. If you're concerned about the airway or the airway is not protected, then you will have to intubate the patients because you don't want or to get further injury to the patients. So airway maintenance or protecting the airway is the main thing that you have to consider. Now, the question is, how would you know if the airway is maintained or protected? You examine the patients, you take the whole picture, you get the GCS, you get the airway examination, you check the patient's level of consciousness, you check if he has any abnormal sounds, does he have stridors, does he have snoring, do you think that he has some salivation coming out of his mouth, does his saturation is dropping? So it's a full assessment of the airway to decide if it's protected and maintained. And if his saturation is okay and he's breathing and he's maintaining his airway, do not intubate the patients, even if his GCS is 8 or 7. Okay? Okay, excellent. So if the patient can handle his secretions, yes, then, or can talk. Sometimes he won't be able to talk because he might have aphasia, but as long as he's maintaining and protecting his airway, that would be fine. So there is, in the research, Takahashi looked at patients with acute stroke who got intubated, and he found that there is a higher level of post-stroke disability associated with intubation. So stroke patients who got intubated, let's say unnecessarily mainly, they might have bad outcomes. So why do they have bad outcomes? And let's start from the left here. Intubated patients are unable to control their respiratory rate. Hyperventilation and subsequent hypocapnia, what will happen here? If it happens, hypocapnia, what will cause? Let's say if he's hyperventilating by the ventilator, we're controlling his breathing. So what happens with hyperventilation and then hypocapnia? What happens to the, no, so what happens to the blood vessel? Vasoconstriction. Yes, excellent. So if there is vasoconstriction, so there will be decreased perfusion to the brain. So there is already a problem with the acute stroke. There is edema. You want higher perfusion to the brain. And if you get hypocapnia and vasoconstrict, this will cause further ischemia. So hypocapnia will result in arterial vasoconstriction. Vasoconstriction results in decreased blood flow to the penumbra and larger infarct area. And this will cause induction with general anesthesia, may cause a rapid drop in blood pressure because to intubate, you're going to give some benzodiazepine, fentanyl, or propofol or whatever sedative to make sure that the intubation gets done. And this will further drop your blood pressure. So it will cause further ischemia to the brain and hypotension. And hypotension may inhibit flow through collateral arteries, which will cause, again, further ischemia and infarction. Longer door to needle times results in increased neuronal death. So because you're delaying this, because you're trying to intubate the patient instead of going directly to the NG suite. And intubation may delay procedure start times, thus increasing the burden of neuronal death. So again, brain is time. So you don't want to lose all these neurons in the brain. So that's why you try to avoid intubation as much as you can safely. Again, that doesn't mean that you don't intubate patients with acute stroke. If the patient is not protecting his airway or having some evidence that the airway is not protected, or he's starting to desat and he's having snoring sounds from his airway, then you have to intubate him, because otherwise he will have more hypoxia, and then eventually he will have more hypoperfusion or hypoxia to the cells, and further ischemia and infarction. So avoid intubation if possible. If intubation is indicated and clearly you need it, then intubate the patient. So in the ED management, there are simple things or interventions that you can do to help prevent the further damage to the brain because of the ischemic stroke, but very important and simple. So what are these simple interventions? You can write it down in the chat box. Okay, O2. What do you mean by O2? Vital signs. Okay. ABC first. So, okay, so ABC first is very important. Elevation of the head at 30 degrees. Excellent. So let me simplify it. There are certain interventions and targets you need to make sure that they don't get affected, because otherwise it will cause further damage to the brain. So what are these parameters that you have to make sure that are corrected? Okay, excellent. Maintain MAP above 80. Above 80 is a bit high. Usually it's 65 to 70, but that's fine. Blood pressure, MAP or blood pressure, make sure the blood pressure doesn't go low or high. CO2, yes, we haven't mentioned CO2. If it's hypocapnia, it will cause vasoconstriction, and we're going to talk about hypercapnia, because that will also cause vasodilatation and may cause further damage because it will cause more brain edema. So you have to balance things. Fever, excellent. You have to control the fever. Glucose, make sure that there is no hypoglycemia. So all of these things are very important when it comes to ED management. So correct hypoxemia and hypercapnia. Make sure that there is euxemia, patient getting adequate oxygenation, adequate balanced CO2. So it's not hypercapnic or hypocapnic. Maintain euglycemia. Make sure the blood glucose level is not hypo or hyperglycemic. Maintain normothermia. So no fever, no hypothermia or low temperature. So you have to correct that. Okay. We have mentioned the blood pressure. So what is the blood pressure management in acute ischemic stroke? So the nurse is asking you, okay, please, doctor, what's the blood pressure you want me to keep this patient on? Depend if there is TPA. Okay, that's a good point. So let's say if there is a TPA, what's your target? Or even if there is no TPA, target is almost the same. Less than 220, okay. What if there is a TPA? Or thrombolytics. TPA is thrombolytic, by the way. 180, 185, okay, close enough. Because you don't want higher pressure if you give thrombolytics, because if you give thrombolytics and the blood pressure is high, they are at very high risk of bleeding in the brain. So that's very important. So if blood pressure is more than 220 or 120 diastolic, you have to decrease it by 10 to 20% change maximum. So you don't want to drop it significantly, because otherwise it will cause further damage to the brain. Why is this happening? Because if there is an acute stroke or ischemic stroke in the brain, there will be changes in the brain tissue and there will be edema, and the edema will cause increased ICP or intracranial pressure. And to overcome this pressure, the body or the heart will increase the vasoconstrictions and push more blood to the brain. And if you drop that, then this will affect the perfusion to the brain or the cerebral perfusion pressure. So please, not lower than 180 over 100 diastolic. So be careful when you watch that. So you don't want to drop it significantly. If it's going to be with thrombolytics or TPA, it's going to be 185 over 110 to qualify. So you cannot give TPA or thrombolytics to a patient with a blood pressure of 200 or 210. Reversible and titratable antihypertensive. Anybody knows what are the examples of reversible and titratable antihypertensive that we can use? Labetalol, okay. Nicardipine. Those are the main two antihypertensive that we like using in the emergency department and in the ICU. So labetalol is the most commonly antihypertensive medication. Amlodipine, not in the emergency setting, because you're going to give it IV. So labetalol is available infusion or PRN push, and also nicardipine if you have it in your emergency. Most of the emergency, they have labetalol as the first line of antihypertension treatments. Stroke severity assessment. So how would you assess the severity of acute stroke? What's the tool that we use in the emergency department by neurologists? The neurologists always use that when they, okay, NIHSS. Okay, excellent. So NIHSS is a score of the stroke severity, and it goes through different levels and categories of neurological assessment. It's basically a neurological exam with a score. So you check the level of consciousness, you check the level of consciousness questions, commands, if they're following commands, best gaze from the eyes, visual field and visual assessment, facial palsy and facial droop, motor left, right, and motor legs left and right, limb ataxia, sensation, best language when it comes to speak, and dysarthria because of looking for the coordination of speaking, extinction, and inattention. Okay. Do you know what's the difference between extinction and attention? They're very close to each other. And sometimes we call it neglect. Extinction, when the physician or someone comes to the right side of the patient and completely doesn't, the patient gets his attention. Like he doesn't know that there is someone looking at him or touching him on the right side because he has extension on the right side. If you check videos of neurological examination for an extinction and attention, it will be much easier for you to assess that. And it's very important. So the patient doesn't have awareness of the right side of his body. The visual field is not reduced in extinction, but the patient is not aware about anything on the right side because it's deep in the brain. So he doesn't know that someone is talking to him or aware about you on the other side. Exactly, him and neglect. It's almost the same as extinction. Okay. Here's an example when it comes to the treatment of acute ischemic stroke. 50 years old plastic surgeon presents with aphasia and right-sided dense hemiplegia started 30 minutes ago. So with this presentation, would you give thrombolytics or TPA or at least offer it or no? Okay, yes. If there is no contraindication, yes. No. Okay. What about the others? Should you give TPA, thrombolytics, or no? CT first, okay. if no contraindication, depends on the score. Okay, so pretty much close when it comes to this answer. But the question is, he's already on the window. It's been 30 minutes and he's 50 years old and he's coming with significant, just by aphasia and right-sided dense hemiplegia, he's already having a high score in the NIHSS score. Now, if you look at the literature when it comes to TPA and thrombolytics, it's interesting because all these studies looked at the TPA use in acute stroke. And if you look at the numbers, this is just updated, I think, in 2020 or 2019. We have more than 10 studies that looked at it. Some studies showed harm from thrombolytics. Some studies showed equivocal or no difference between giving TPA or not. There were only 2 studies that had benefits. The NINDS 2 studies and the ECAS-3 study. The NINDS was within 3 hours, and the ECAS was between 3 and 4 hours and a half. Mainly the NINDS is the most important study that looked at the benefits, and it had 13% absolute benefit at 90 days post TPA, but there is an increased ICH, but overall there is an improvement. My point here is that thrombolytic, it's not a magic drug that will fix every acute stroke patients. It is very helpful in certain group or subcategories of patients. Our job as physicians to make sure that is this patient within the right group, because if he's not in the right group, probably you will kill this patient. So we have to make sure that did he come within 3 hours? Sometimes I get calls about a patient and they tell me, oh, this patient comes in with a stroke, and then they tell me that it's been started like 30 minutes. I asked them, how did you know that it started 30 minutes ago? They will tell me he woke up and 30 minutes ago from sleep, and then he was found to have stroke. But I said, okay, did he have the stroke while he's sleeping? What was his situation yesterday? Because you need to know when was the last time he was fine. So that's very critical, because if you give it to the wrong patients, you might harm him or even kill him or affect him with a disability for the rest of his life. So it's very important to get the history, very detailed history and accurate. When was the last time the patient was seen normal? You ask the family, his kids, his son, when did you see him last time? Well, I saw him last time at 11 p.m. before I went to bed. Okay, and he came in at 7 a.m. To me, it's more than 6 hours or 7 hours. If they told me, no, we were with him eating dinner, and then suddenly while we were eating dinner, we saw his face drop. He was holding the spoon and it dropped from his hands, and we came immediately 1 hour ago. Then, okay, this is exactly the last time he was seen normal. So that's very critical when it comes to getting the full story properly, or the history properly, and the clinical examination properly. And most of the societies and the emergency department, the American Academy of Emergency Medicine and the American College of Emergency Medicine, they will give you an idea. If patients with an acute ischemic stroke and they came and presented within 3 hours, by the NINDS protocols, if you give them, there is a chance that they will get better without treatment. Like you can see from this group, there is 6 people, they might get better. If you give them the TPA, the chances will increase compared to before, maybe like 10% increase, but one of them will have a brain bleed and may die at a risk. But some of them, they will say, you know what? I'm a plastic surgeon, I'm a musician, I will take my chances. Even if there is a small risk of brain bleed, I don't want to end up with a disability for the rest of my life. So that's why most of us, we push for giving the TPA to the right patient to make sure they get the chance. Okay. So here, this is the recommendations or the guidelines from the American College of Emergency Medicine from 2012, 2015, and the recent one was from 2015. It wasn't updated since then because there was no big studies that actually looked at it. So is IV TPA safe and effective for acute ischemic stroke patients if they were given within 3 hours of symptom onset? Level A, there is no evidence, but there is an evidence which is level B, which is moderate, which is good. IV TPA should be offered again, should be offered to the patient. They did not say should be given. They said should be offered. So that makes a difference. I will talk to my patient, I will talk to my family, look, we have a medication that can help uh, bust the clot and dissolve it, and it will help you make you better. And we offer this medication and we can give it. But there is some risk with that, small risk that you might end up with a bleed in the brain. So at least you explain that to the patients, and mostly with the neurologist. You need the neurologist to help you in making such decision because he will also give you a better understanding of the condition. The second part is IV-TPA safe and effective for acute ischemic stroke patients treated between 3 to 4.5 hours after symptom onset? So here they say clearly it's may be offered and may be given to carefully selected acute ischemic stroke patients. So it means that the more delay you have, the chances of improvements is going to be diminishing with time. But always offer it to patients who are presenting within 3 hours of presentation. Again, this is the same thing. It's a chance of getting better. There is some small risk, but some people, they would take the risks instead of ending up with a permanent disability for the rest of their lives. This is a website that looks at the thrombolytics evidence for acute ischemic stroke. Before, they said there was no benefits found, but there was a recent update because people, they interpret the studies differently. So be careful when you're reading studies or papers. You have to understand what were the criteria, what were the group included, and people sometimes they interpret it differently because some studies are very clear that shows benefits. Some studies are not very clear or straightforward when it comes to giving the idea that there is significant benefits. So here in this the same study, the NIND study, TPA for acute ischemic stroke, if it was given within 3 hours, the number needed to treat is 10, which is pretty good for those patients, especially if they will end up with a significant neurological deficits. Obviously, the more delay you have, the number needed to treat will go down. So that's why we target 0 to 3 hours. And if you can see the harms, there is already a harm from 0 to 3. Number needed to harm is 40. And then if it's 3 hours to 4.5, it's going to be 50. And surprisingly, 4.5 to 6 hours, it's going to be 40. But again, this is from one study. The new studies have changed that number. And usually when you delay the management or the TPA, the chances of disabilities will increase. Okay. Now, the good thing is that our acute stroke patients, ischemic stroke, obviously, they have more advanced treatments, which includes endovascular treatments in the NG suite or the interventional radiologist who are now becoming more professional when it comes to removing or evacuating the clot mechanically with the instruments, obviously. Here, there are different studies that looked at the endovascular treatments, which is the mechanical thrombectomy to remove the thrombus from the arteries in the brain. At the beginning, it was started from 2013, and the studies are becoming more and more popular within the past 10 years. And you can see that at the beginning, there was no benefits, and then we can see that there is the more specific subcategories of patients you choose, the disability benefits will improve. Like here in the ESCAPE study, they had 24% disability benefit, which is great. And you can see in the extent IA study, there was a 31% disability benefit. So there was always benefits that we can get from doing it to the right targeted population or subcategories of patients with an acute stroke. And the question is, what is this subcategories of patients that will benefit from endovascular treatment so we can get them done or send them to the right facility, because not all hospitals have endovascular treatment or neurointerventional radiology. So there is some limited population will benefit from it. So patient with severe strokes, up to 24 hours window. So you can treat those patients up to 24 hours, not only just within 3 hours. And mostly the people or the patients who will benefit from it, patients with proximal large vessel occlusion and patients with salvageable brain tissue. So severe stroke, you can tell from the NIHSS score, you know that this is a severe stroke. Up to 24 hours window, you know the window because you ask the patients when was the last time he was seen normal. Salvageable brain tissue, it's a bit challenging. You need like a specific advanced imaging machine, which is not available in all hospitals. Proximal large vessel occlusion. How would you know? This is the very important thing that you need to know. How would I know this patient with an acute ischemic stroke has a proximal large vessel occlusion? Because if he has proximal large vessel occlusion, you have to think about mechanical thrombectomy for this patient. Okay, so how do I know if it's a large vessel stroke? Because if I knew, then I would send him to a center or a facility with an interventional neuroradiologist to get an endovascular intervention. So you can use the mnemonic weak van. So what is weak van? Anybody have heard about this mnemonic? You can write it down in the chat box. Okay. I guess if you Google it or ask ChatGPT, it will give you the answer if you ask about large vessel occlusion. But to keep it simple, weak, it's weakness. The patient has right-sided weakness or left-sided weakness, so he's going to present with unilateral weakness. Van is the mnemonic, so he has some visual problem, visual complaint. Aphasia, so he has some forms of expressive or receptive aphasia. We're going to talk about that. And N, neglect or extinction. So he has to have neglect to consider him for endovascular. We're going to go through these. So step one, you have to check for weakness. Ask the patients to raise both his arms and for 10 seconds and assess for drift. Drift is the hand or the arm are drifting away because of weakness. So if there is weakness or paralysis, if any of these are present, proceed with step two. So if he has weakness or paralysis, go to step two. And step two, again, you use the Van mnemonic. So he has either visual problem or aphasia or neglect. So again, what we have here is or. So you don't need all three of them to see if he's a candidate for endovascular treatment or not. If he has only just right-sided weakness and aphasia, he's already a candidate for endovascular intervention. Does that make sense? Okay. So visual disturbance, field cut, diplopia, or blindness. So you ask the patient, you ask him for visual assessment, visual field assessment. Can he see my finger? You do the visual assessment, visual field assessment. Diplopia, you can see if there is any abnormal extraocular movements. Blindness, if he's not seeing or if have visual problem or blindness. Aphasia, expressive or receptive. So expressive, you ask the patients, repeat and name two objects. You give him two objects and you tell him, okay, please repeat after me. قلم مسطرة. ردد معي. ايش قلت قبل شوي؟ قلم مسطرة. فإذا ما كرر, if he did not repeat it, then he has expressive aphasia. Receptive aphasia, unable to follow commands. You ask him, close your eyes. قفل عيونك. He's not closing his eyes. ما يسكر عيونه. Make a fist. سوي لي كذا. سوي لي بقبضة يدك اليد اليمين. If he's not following commands, he has receptive. He doesn't understand what you're saying. He doesn't understand the command. Neglect, we have mentioned before, inability to track to one side, ignoring one side. So he completely ignores what are you doing on the right side. So if we touch his hand, so you can ask him, are you feeling my hand? He will say no, or he will feel it on the other side. So he's not sure if you're touching him on the right side because he's completely ignoring, he's not aware about the other side. Unable to feel both sides at the same time or unable to identify own arm. So he's not able to identify his own arm on the right side because he has neglect, or even if you touch him on both sides, he cannot tell if you're touching both his arms or one side. So again, you need one of them. You don't need all of these three. So either visual disturbance or aphasia or neglect in addition to the weakness. So the weakness has to be there. So here, a quick pathway of the patients. So if it's within 0 to 4.5 hours, all strokes type, they go to plain CT and CTA, and they might be a candidate for TPA plus minus thrombectomy. So they can get thrombolytics and then they get thrombectomy. If it's between 4.5 hours and 6 hours, depending on the NIHSS score, because endovascular intervention will benefit from patients with significant disability or high score of NIHSS. So if it's 6 and more, then you would consider them for endovascular thrombectomy, or you can use the VAN positive, which is weak VAN. He has weakness and one of the visual or aphasia or neglect. So you're going to do plain CT, CTA. CT perfusion is basically, it will be an advanced imaging. It's not available in most hospitals, but it will give you the perfusion of the brain overall. And those patients will benefit from thrombectomy. 6 hours to 24 hours, if the NIHSS score is more than 10, and you can use the weak VAN, also mnemonic, and then you do this plain CT and the CT and the CT perfusion, and those patients also may benefit from thrombectomy or endovascular intervention. Stroke units. Stroke unit is now, it's becoming more popular, and most hospitals now, they're developing their own stroke units. And why are we having stroke units in the hospital? The evidence says that organized inpatient stroke units caring for stroke patients, most of the studies and the meta-analysis, they found that stroke patients who receive organized inpatient care in a stroke unit are more likely to be alive, independent, and living at home 1 year after the stroke, because it's a bundle of multiple intervention. The benefits were most apparent in units based in a discrete ward, so dedicated ward for them. We observed no systematic increase in the length of inpatient stay. So because they have specific protocols or the supportive services available, and they make the patients improve dramatically in stroke units if it's in the hospital. So in summary, this is only for the stroke, acute ischemic stroke. In the emergency department, always be vigilant not to miss an acute stroke. Second, always rule out the mimickers of acute stroke. Offer TPA if within the window. So we have to offer the TPA if it's within the window. Mechanical thrombectomy is becoming more popular and effective, and actually it may become the first line of treatment with advanced medicine interventions. Simple things, but very helpful and will prevent further damage. Correct hypoxemia, hypercapnia, maintain euglycemia. We hate hyperglycemia. We hate hypoglycemia. Maintain normothermia, no fever, no hypothermia. Make sure that this is all corrected. Okay, Dr. Sulafa, she's asking about CT perfusion is the same as CT with contrast? No, it's different. It's a different modality. It's an imaging modality that looks at the perfusion within the brain, looking at the perfusion at the level of the cells of the brain or the brain tissue. It's different from the CT with contrast or the CTA. Okay, we're going to have some questions also at the end. We're still probably halfway. I think we still have time. We're going to go through the secondary headache, which is very important in the emergency. The primary headache, it's basically a secondary headache that causes that has been ruled out. But the secondary headache is basically devastating when you miss it. So it's very critical to think about these secondary headaches in the emergency department. We're going to go through the definitions, the objectives, definitions, classification, subarachnoid hemorrhage diagnosis and management, intracerebral hemorrhage diagnosis and management, and lastly, cerebral venous thrombosis diagnosis and management. So what is the classification of hemorrhagic stroke? I think I've mentioned it in the first slides. So anybody remembers the classification of acute stroke? So there are two big categories. What are they? So classification of acute stroke. Okay, excellent. So ischemic and hemorrhagic, as you have said. What about the hemorrhagic? What are the classification or the subcategories of hemorrhagic stroke? Okay, subarachnoid hemorrhage, traumatic. Some people they will say traumatic or non-traumatic, and intracerebral hemorrhage. Excellent. So an acute stroke, ischemic, we have already mentioned that, hemorrhagic stroke, including subarachnoid hemorrhage, intracerebral hemorrhage, and as we have mentioned before. We have went through the definitions and the ischemic stroke versus hemorrhagic stroke in the previous slides. And now, this is the most important thing for us in the emergency department. What are the red flags in a patient who's presenting with secondary headache? Or even someone calls you, you're in medical school, a friend calls you, I have a headache. Should I go to the emergency department, or should I wait or just take Panadol and that's it? So what kind of questions will you will ask the patient or your colleague? Okay. Is it worst headache of your life? Yes, excellent. So you need to know if it's the worst headache of your life. Take some minutes to listen to his mom. Ahmed. Okay, I think that's fine. طيب, going back, fever, focal neurological deficits, end organ damage, severity in onset, not improving with analgesia, loss of consciousness, any neurological symptoms, systemic symptoms. Is it sudden and gradual? Focal neurological deficits, vomiting, neurological. Okay, so you guys, mashallah, you're giving us a lot of love. And someone mentioned Snoop 4. Okay, excellent. What is Snoop 4? This is a mnemonic, obviously, but what is Snoop 4? Or Snoop in general? It's Snoop. Some people they use Snoop, some people. Headache with neck stiffness. Okay. Stable or not. So someone mentioned Snoop, which is a mnemonic that may catch potentially life-threatening headaches. It's as you have mentioned in the chat box, but it's in a mnemonic um, uh, organization. So S is for systemic signs and disorders. So maybe he has fever, he has significant weight loss, any systemic signs and disorders. Neurological symptoms. He had sudden weakness, he had some difficulty speaking or aphasia, he has some visual problems. Onset new or changed in patients above 50 years old. So patients who are above 50 years old, you have to be careful with them when they come with a headache. Always, as myself, any patient with 50 years old with new headache, he will get a CT or imaging to make sure that it's not something bad. And if it's an onset is new or changed. So he said, this is something new in my headache. It's like the first time I had it. أنا ما قد جاني الصداع زي هذا قبل كذا. Onset thunderclap presentation. Excellent. Thunderclap presentation. You need to all of us mention it as a cause of subarachnoid hemorrhage. Papillary edema, pulsatile tinnitus, positional provocation precipitated by exercise. So precipitated by exercise, that when he exercises, he gets the headache or he gets the secondary headache. Positional provocation, when he moves or stand up, he gets the headache. So Urjuan, he posted the Snoop papilla edema, positional. Obviously, some people they have different interpretation of it, but always think about the red flags in headache. If you use Snoop, use something else. Always think about the red flags for headache. Onset, thunderclap onset it's new or changed. Patients above 50 years old, neurological symptoms, papilla edema, pulsatile tinnitus, systemic signs and disorders. This is very important in the emergency department or any patients with headache. Okay, 30 years old male complaining of the worst headache of his life. The headache hit him like a bolt out of the blue, and he has been unremitting ever since. What's your differential here? Subarachnoid. Okay, so I guess most of you already see it. It's subarachnoid hemorrhage until proven otherwise. Excellent. So what is the etiology of subarachnoid hemorrhage? What causes subarachnoid? Trauma. Okay, this is traumatic subarachnoid. Let's talk about non-traumatic subarachnoid. Aneurysm rupture. Okay. Hypertension. Okay. Anything else? Hemorrhagic stroke. Well, hemorrhagic stroke because it happens because of something. Hypertension, aneurysm. So 85% and maybe up to 90% are ruptured aneurysm. So there is an aneurysm in the brain. It's been there for years and suddenly it ruptures and then the patient comes to the hospital with subarachnoid bleeding. Yes, cluster headache, it's different, obviously, and it's a primary headache. It's not a secondary headache, common in males, yes, but it's not a secondary headache, and there is no bleeding in it. But it comes with sudden onset and severe headache. 10% of subarachnoid bleed is perimesencephalic hemorrhage, and less than 5% are AV malformation or inflammatory causes or because of drug use, such as cocaine. Inflammatory, such as chronic inflammatory disease or rheumatological disease, such as vasculitis, SLE, systemic lupus erythematosus. What are the risk factors for aneurysm? Okay, so this is again, you have to ask about that when a patient comes in with a secondary headache. Risk factors for aneurysm. Okay, hypertension. What else? Polycystic kidney. Okay. Smoking. Excellent. AV malformation. If he knows if there is AV malformation, for sure it will be a risk factors. But most of them, they don't know that they have it. Connective tissue disease. Okay. Okay, so you have mentioned some of it, but the most important factor is family history and smoking, hypertension, heavy drinking. Those are the top four. Family history, you have to ask the patient, did any of the family has any bleeding in the brain or aneurysm in the brain before? Smoking history, hypertension, heavy drinking or alcohol drinking is also a risk factors. Mostly common in females compared to males. And use of oral contraceptive pills might increase the risk of subarachnoid bleed. Clinical features. So what are the clinical features that you would see in subarachnoid bleed? So what's the presentation of a subarachnoid bleed patient? Worst headache that we have mentioned. What else? Okay. Star, maybe you mean in the CT scan. Photophobia, loss of consciousness, vomiting, confusion, meningitis-like symptoms, nausea. Okay. So probably you got most of it. So headache, obviously this is the main thing. Thunderclap headache, that's, you have mentioned it already. 1 in 10 people with a thunderclap headache will have had a subarachnoid hemorrhage. So it's very important to ask about the thunderclap headache. بدأ فجأة كده suddenly كده مفاجئ. Onset may not always be instantaneous. And what we call this, if it's instantaneous, it's going to be 50%, 2 to 60 seconds, 24%, 1 to 5 minutes, 19%. So that means that the headache started within a few minutes, but most of the time it's like within 2 seconds or 1 second is just suddenly a thunderclap headache that started instantaneously. But again, some of them will present or I start like within 5 minutes as a presentation. So there is a subgroup of non-instantaneous presentation of headache in a subarachnoid bleed. Some of them they'll tell you I have no idea, and I don't remember. I'm not able to remember how did it start? Few minutes, 1 hour. I'm not sure. Clinical features. Some of you have mentioned it. There is something called the sentinel bleed. Do you know what the sentinel bleed is? Anybody have an idea? It's associated with subarachnoid bleed. Over time. Okay. So sentinel bleed is basically the patient have a small bleed in the brain from an aneurysm, and then it stops. And the patient, what he feels is that a sudden onset of headache that improves within a few minutes. And then he goes back to his normal daily activity. So what happens is that those patients, he will remember when they present with subarachnoid bleeding and they're very sick, they will say, yes, 1 week ago he had some a transient headache for a few hours or for like 1 hour, and then it's gone by itself. Vomiting is not predictive, so it's not helpful to get the vomiting. Seizures, they will present, if it's severe, they're gonna have seizures. Altered level of consciousness, they might present with complete comatose, depending on how bad is the bleed. Neck stiffness, you have mentioned that, because the bleed, it goes to the meninges and then can cause a neck stiffness. Cranial nerve palsy, they will have diplopia, visual changes, any cranial nerves weakness. 1 in 7 will have intraocular hemorrhage, so they will have bleeding in the ocular in the eyes, and you can see it here. So this is a fundoscopy examination of the eye. So what do you call this sign? Anybody knows? So this is called subhyaloid hemorrhage. You might get it on an exam, so they might ask you about this. It's a sign of subarachnoid bleed. What about this ECG? What do you guys see here? Deep T waves, and there is ST depressions. Okay. So you can see some abnormalities that may go with ischemic changes. So again, if the patient comes with ischemic changes or a headache or suspected subarachnoid bleed, this might affect the cardiac activity, electrical activity. So they may show some ischemic changes, which technically because of the subarachnoid. So be careful you have to ask about if the patient comes in with abnormal ECG, ask about headache and any cardiac symptoms, just to gather all information together. ECG abnormalities are common in subarachnoid bleeding. 3% will have a cardiac arrest because of subarachnoid bleeding, and sometimes the cardiac arrest because of the arrhythmia from the subarachnoid bleeding if it's really large and affecting a certain area of the brain. So is there a screening tool for the subarachnoid bleeding in the emergency department that we can use? Anybody knows? So let's say it's a scoring tool that looks at Ottawa. Okay, excellent. So Taif, apparently she knows it. So what is the Ottawa screening tool for SAH or subarachnoid bleed? So there are basically 6 components you're going to ask about. Anybody knows what are these 6 questions? Because if the 6 questions, all of them, the patient tells you no, it's very unlikely to be a subarachnoid bleed. Anybody knows at least these Ottawa? If you Google Ottawa SAH score, then you can find it. So the age, neck pain. Do you know what's the age? Loss of consciousness. Okay. 40. Okay, good. I guess most of you have found it. Okay, so that's good. So this basically, it looks for patients who require investigation if one or more finding is present. So 6 questions. This is basically to rule out for patients who are alert and 15 years old and above with new severe non-traumatic headache. So you cannot use it on traumatic headache, reaching a maximum intensity within 1 hour. Not for patients with neurological deficits. So if he's already having neurological deficits, you don't apply this rule. If he's known to have previous aneurysm, you don't apply this rule. If he has subarachnoid bleed or brain tumors or history of similar headache, or more than 3 episodes over the past 6 months, those are not included in this rule. So you don't apply it to all group of patients. The 6 questions: does the patient have symptoms of neck pain or stiffness? What's his age? 40 years old and above or not? Witnessed loss of consciousness. Was the onset during exertion while he's doing exercise and it started suddenly? Was it a thunderclap headache? Peak intensity immediately within 1 second. Does he have limited neck flexion on examination? So these are the questions. If the patient tells you no, and it's part of the inclusion-exclusion criteria, then you can say auto-ICH rule is negative, so it's unlikely to be subarachnoid bleed. And even you don't need the CT scan to scan him. So what test do you want me to do? So the nurse is asking you, let's say if you're suspecting a subarachnoid bleed, so what test do you want to do for this patient if you're suspecting subarachnoid bleed? CT. Okay, so CT is the first thing to do. LP. So do you need to do LP for all subarachnoid bleed? Depends on the time. Excellent. Blood gases. Okay, blood gases, you need to check the blood gas situation and the perfusion. 6 to 12 hours. CT. Okay, so we're going to go through that. So CT scan is basically 98% sensitive if it was done within 12 hours of onset, which is not bad, and more than 99% sensitive if it's within 6 hours. Keep in mind that if it's subarachnoid bleed, if you miss it, it's going to have a devastating, a bad outcome to the patients. Okay. Someone says that LP after 12 hours negative CT with high suspicion. Okay. It is some practice that we do right now. Lumbar puncture 12 hours after onset of headache if the CT scan is negative. Do not do a lumbar puncture if the CT scan was not done. And why do we don't want to do a lumbar puncture before CT? Okay, herniation. Excellent. So you can do that, rule out subarachnoid bleed with the CT, and if it's more than, if it's negative, then you can do the lumbar puncture. CTA, it has more and more roles, and I'm going to talk about that later. This is the lumbar puncture we're looking for. It's basically xanthochromic changes, color. This is with the LP. But usually the CT now, the new advanced CTs will be very accurate in ruling out bleeding in the brain. You can see here, this is the diagnostic studies from 2015 until 2021. The blue circles are the CT scan. It's becoming more and more popular, and it's the way to go to rule out bleeding as long as it's presented early. So if you have a patient, you suspect subarachnoid bleed and he's in your emergency department, do not wait for the CT scan. Get the CT scan as soon as possible, because the more delay, the more difficult to diagnose him for or to rule out subarachnoid bleed. And you can see there is a drop of using lumbar puncture. From 2015, it's more common to use the CT with contrast because it will show you if there is an aneurysm or not. So people now, they're using CTA more than lumbar puncture. If you have lumbar puncture and don't have CTA, that's fine, you can do it. But CTA now, it's becoming more and more popular if it's more than 6 hours or 12 hours. Yes, lumbar puncture, no, it's not you use lumbar puncture to diagnose meningitis. If it's contraindicated meningitis, if you're concerned about herniation, if there is increased pressure in the brain. So that's why you have to do the brain CT to make sure that there is no edema. If there is edema in the brain, then do not do lumbar puncture. Okay, there is a clinical classification of subarachnoid. There is the Hunt-Hess scale. And recently, most neurologists and neurosurgeons, they're not using it. They're using the World Federation of Neurological Surgeon for subarachnoid grading. And it's basically based on the GCS grade and presence of or absence of motor deficits. So if it's 1, it's a GCS of 15, absent no motor deficits. 2, GCS is 13 to 14 with absent motor deficits. 3, 13 to 14, and there is motor deficits present. 4, 7 to 12 GCS. It doesn't matter about the motor deficits for 4 and 5. And 5 if the GCS is 3 to 6. ED management, you have mentioned that. ABC, analgesia, systolic blood pressure control, to keep it between 140 to 160. You don't want to drop it significantly, and you don't want it to go high, because if you lead it going higher more than 160, it will bleed more. If you go down below 140, then the risk of ischemia will be higher. Again, normothermia, prophylactic antiemetics for vomiting, all of these things you have to consider. There are some questions. Can you repeat again concerning CTA is more sensitive after 12 hours? CTA now it's becoming the same as a lumbar puncture. Lumbar puncture is more sensitive, but we're talking about 99% compared to 98%. So it's not a significant difference. So if the protocol at your hospitals prefer CTA and to avoid a lumbar puncture, that's fine. If the hospital does lumbar puncture and not CTA, that's also fine. Certain indication, right? Not all patients I will do CT before LP. No, it's better to do CT before LP because sometimes it's difficult to do it clinically or to assess the patient clinically. Does it differ if we did a CT scan without contrast? Yes, the CT contrast will show you the aneurysm, will not show you the bleed. The plain CT will show you the bleeding in the brain tissue. The LP I have showed you before is basically the xanthochromia. For people who have not seen it, this is the xanthochromia. It's going to be yellow discoloration of the CSF. This is xanthochromic changes in subarachnoid bleed from lumbar puncture. We're going to go through these questions at the end, so I just don't want people to wait. You can keep the questions, write your questions, and then we're going to go through them one by one. I think we have time for almost up to 30 minutes. Okay, so that's the ED management. The most important thing, obviously, after the ABC is the systolic blood pressure. Between 140 and 160. The magic number you're trying to reach is 150 systolic, which is between 140 and 160. You can see here, this is a bleed in the brain, intracerebral. Intracerebral hemorrhagic classification, it's either going to be primary or secondary. Primary is spontaneous rupture of a small penetrating arterioles damaged by chronic hypertension or amyloidosis. Secondary is because AV malformation, post-infarct bleed, tumors, bleeding diathesis or coagulopathy, vasculitis. Risk factors for ICH. Again, we have risk factors for subarachnoid and there are risk factors for ICH. So ICH is hypertension both in SAH and ICH. Heavy ATOH intake, both in SAH and ICH, subarachnoid and intracerebral. Cocaine use here in intracerebral hemorrhage. Advanced age, because the arterioles becomes more fragile. Male, African ethnicities, they have higher risk of ICH. Management goals: prevent hematoma expansion and complications, prevent secondary injury. And how would you prevent secondary injury to the brain? We have mentioned it before. What are the simple things that would help prevent the secondary injury to the brain? BP, normothermia, control the blood pressure and the sugar, avoid hyperglycemia, avoid also hypercapnia and hypocapnia. This is simple, but it's very important. And people or physicians, they miss it and they forgot about it. Okay, excellent. Resuscitation, secure the airway if needed. Ventilatory support, intubate if it's needed. Control the blood pressure. Controlling blood pressure in subarachnoid and ICH, labetalol, usually it's the best option. Systolic blood pressure here, we need it below 160, okay? 160 to 140 is fine. Airway, rapid sequence intubation, pre-treatment with fentanyl. Fentanyl will decrease the effect on the intracranial pressure, so it will not cause more bleeding when you intubate the patients. The best induction agent, anybody knows? Probably it's an advanced question at your level, but anybody knows what's the best induction agent to intubate the patients with ICH? Etomidate. Etomidate is an excellent choice. Some people, they would use ketamine, but etomidate would be the best. Reversing coagulopathy. So if the patient is already on warfarin, if he's bleeding because of ICH, you need to reverse the coagulopathy. So how would you reverse warfarin? Anybody knows? Vitamin K. What else? Vitamin K will take time. FFPs. Okay, what else? That is more faster than FFPs and effective. Okay, some people they were saying PCC, prothrombic concentrating or Cacentra. So this is something that applies to intracerebral hemorrhage or any bleeding. If you want to reverse coagulation, there are multiple classes of anticoagulants. So warfarin, vitamin K, and 4-factor PCC or Cacentra, or FFPs if it's not available. Vitamin K will take time, so it will take 2 days. So you cannot depend on vitamin K. You have to give PCC as the first line. If it's heparin or low molecular weight heparin, it's going to be protamine. Protamine will help with that. Dabigatran, then use the antidote, which is the idarucizumab. This is the antidote for dabigatran. If it's apixaban or rivaroxaban, then you use Andexa. Andexa is the antidote. If it's not available Andexa, then you can use PCC as an alternative. So this is going to help you for any bleeding patients with anticoagulants. ICH management, reverse coagulopathy, we have mentioned that. Heads up. So why do we elevate the bed 30 degrees? Do we know why? So usually a patient with in the ICU or even with bleeding, they put them on 30 degrees. Reduce congestion. Yeah, you're right. So because if they lie flat, the blood will congest or be stagnated in the brain, and it will cause edema. And if you have edema in the intracranial vault or skull, then it will increase the ICP. And if the ICP increase, then the cerebral perfusion will go down. It will affect the perfusion and it will cause ischemia. So heads up is very important in those patients. Intracranial pressure monitoring. So some neurosurgeon will come and put an EVD to monitor the intracranial pressure because you want to control the cerebral perfusion. Osmotherapy for high ICP. You want to decrease the ICP so the perfusion and the cerebral perfusion goes up and improve. Fever control, the simple measurements that we do. Seizure prophylaxis. So it's controversial when it comes to seizure prophylaxis. If it's a non-traumatic ICH and the patient did not seize, we don't usually give seizure prophylaxis because it doesn't have benefits usually and it may cause harm. But if he's seizing or if he has active seizure, then absolutely we'll have to treat him with antiepileptic. Euglycemia, we have mentioned that as part of the simple intervention for ICH. The last topic is the cerebral venous sinus thrombosis or the forgotten headache. So this is basically a cerebral venous sinus thrombosis. It's not as common as the others, but it presents to us in the emergency. It's basically a venous thrombus in the cerebral venous system. We have the sagittal sinus, transverse sinus, cavernous sinus, sigmoid sinus. So all of these venous system may get a cerebral venous thrombosis. What are the risk factors that you have to think about for CVT? Anybody knows? OCP, female, excellent. Oral contraceptive pills. Previous episode. Okay, so we have mentioned most of it. So the most important thing is thrombophilic state. Does he have coagulopathy or thrombophilic state? Oral contraceptive, because it will increase the thrombosis in the body. Period in the patient's postpartum. Central nervous system infection. Systemic inflammatory states such as lupus or inflammatory bowel disease. Cancer patients. Hematological disorders. Neighboring sinus site infections such as sinusitis. All of these things might cause cerebral venous thrombosis. The most important risk factor is, does the patient have a thrombophilic state? So what do you need to think about this in the ED? When do you think about that? So a patient coming in with headache, obviously, they most commonly present with headache. So if you have unexplained severe or prolonged headache in a patient with thrombotic risk factors, again, thrombotic risk factor. They're using oral contraceptive. They have antiphospholipid, they're bedridden or they're immobilized. Any thrombotic risk factors, you have to consider it. Patients with symptoms consistent with raised ICP, especially in patients with thrombotic risk factors. Patients, if you examine his eyes, you see papillary edema. So why does he have papillary edema? Does he have any thrombotic risk factors? Thunderclap headache in a patient with thrombotic risk factors who rules out for subarachnoid bleed. Okay, so thunderclap headache is usually associated with subarachnoid bleed. But if it's has been ruled out, think about CVT or cerebral venous thrombosis. Stroke patients who present with seizure, severe headache, or neurological finding that do not fit clear arterial distribution, so they don't fit the MCA territories. So you have to think about that. Think about central venous thrombosis in such patients with acute stroke. By the way, some literatures they label central venous thrombosis as an acute stroke also. So this is an interchangeable name sometimes. Intracranial hemorrhage that doesn't fit a classic pattern, especially if there are multiple bleeds or the patient is young. So this is to keep in mind. So central venous thrombosis can come with a bleed in the brain, but it's scattered bleed. It's not like in one specific artery or site of bleeding. Diagnostic imaging, you need CT venous study to look at the venous system of the brain. MRI or MRV, which is an MR of the venous system. You can see here, you can see this is a clot in the sagittal sinus. So in summary, always think about the red flags in a patient with headache. Red flags is the most important thing. The problem is not with the diagnosis in terms of doing the CT, doing the treatment. Most of the patients, they have severe disability because they got missed. They present to the emergency and nobody picked it up, or they dismissed them and sent them home and they came back later the second day or after 24 hours in a devastating state. So always think about the headache and ask the right questions. Subarachnoid bleed, get the CT within 6 hours. Do not delay those patients. Get the CT scan within 6 hours. You can use the Ottawa SAH rule to screen. It's sensitive but not specific. If it's negative, that's great. But if it's positive, you have to investigate and go through the CT scan and check if there is a bleed or not. Perform an LP when indicated to rule out subarachnoid bleeding. For example, it's been 12 hours, 14 hours, and we don't have a CTA, or you don't want to do a CTA, it's not available, then go ahead with the LP after the CT scan, obviously. Always have a high suspicion for CVT or central venous thrombosis. And that's it. And sorry for keeping you waiting. Any questions? I think we might have 10 minutes for questions. I'm not sure how would you guys do it. You want to do it in the chat box? You want to do it through the mic? Like in the organizers, they can دكتورة سلافة if you're with us. الله يعافيك.
Yes, موجودة. As they like, دكتور. اللي حابب يفتح المايك يسأل، اللي حابب يرسل في الشات.
If they want to write it down, that's fine. If someone wants to ask the question, please raise your hand so we can go one by one. Okay, Isa is asking about his classification uses in mortality in the ED. Before we use the HIS classification, I'll go back to it. But recently, most of the studies and most literature, they look at the World Neurological Federation classification, because this is the standard. It's more accurate in terms of classification. Hunt and HIS usually focuses on the symptoms and the neurological deficits into 5 levels. But the World Federation of Neurological Surgeons is the accurate and the best, most studied classification. Any other questions? I'm not sure. I don't see the hands. So if someone wants to ask a questions from the group, they can raise their hands, or you can write your question. That you sent the lecture. I will try. I might send it in PDF. It's actually sometimes it's available with some of the residents, but that's fine. I can share it with you guys. Okay. I guess nobody has raised his hand, so nobody wants to ask questions from on the mic. But we can wait 1 minute. If anyone has any questions, and then maybe we can close. Okay. Well, okay. So there is one question. Okay. Interesting. Thank you very much. When you suspect CVT, and as you said, it sometimes overlap with stroke in literature. If you do a CT, CTA, do you get back to do CTV again? Yes, basically, if it's a central venous thrombosis, you might see it on the CT or the CTA, depending on the radiologist and the image that they got. But if you're suspecting a a central venous thrombosis, and you want to rule it out, you have to get a CTV, a venous study. Otherwise, you won't be able to rule it out. Can you repeat why we don't intubate stroke patients? Probably I mentioned in the other side. It will cause more further damage to the ischemia. It will cause more ischemia because you're giving hypotension medication. It will cause drop of blood pressure. You might cause hypocapnia, which will cause vasoconstriction. So with the whole process of interventions will cause further damage to the brain. I'm not saying do not intubate the patients. If he needs intubation, if he's desatting and he's snoring and he's not protecting his airway, you have to intubate, otherwise he will die. Okay, so hopefully answered these two questions. Any further?
Doctor, I have a question, please.
Okay.
Is the weak fan mnemonic, we can replace it by an IHS? Yes. Well, we have to do it both.
Uh, I think you have to do it both better. If you can get them both, the NIHSS as part of it is the weak one, because you're going to ask about these questions in the NIHS. You're going to ask about visual field. You're going to ask about aphasia. You're going to ask about weakness. The difference is that the weak van is basically an easy way to, instead of going through the NHS, and a fast way of doing it. So that's the difference. If you're going to use one of them, use the NIHSS. And if it's more than 6, you have to consider large vessel occlusion. Okay. Someone is asking when to do CT with contrast and when without. It depends. You're looking for subarachnoid, or you're looking for CT in ischemic stroke, because it depends on the disease you're looking for. I'd like your opinion in this low-risk patient with TIA and follow up and start antiplatelets on them and the use of ABC score. So the ABCDE score, it's different. I did not talk about it because it's the transient ischemic attack. Usually we use the ABCDE2 score, and depending on the score, you can classify the TIAs, if it's high risk or low risk. And depending on the score, you can start antiplatelets. But I think the main important thing is you have to make sure that he will be seen by a neurologist within like a specific time. So within 2 days, within 3 days. If he is not going to be seen by neurology within 2 days or 3 days, it's going to be seen within after 1 month, then you have to ask neurology to come and see the patients to arrange the follow-up. Okay, so just to answer the question, CT without contrast or with contrast, this is maybe if it's for subarachnoid bleed, it's always CT plain. If it's delayed more than 12 hours or more than 6 hours, you can, we usually ask for the CT with contrast because we want to look for the aneurysm. Okay, يعطيكم العافية جميعا. Thank you very much. Thank you for your time, and hopefully it was useful. And بالتوفيق في بقية المحاضرات. موفقين إن شاء الله.